Welcome to the third session of Socialist Perspectives on Public Health, sponsored by the Socialist Caucus of the American Public Health Association. I'm Ken Rosenberg. I will be moderating this session. I want to start with a land acknowledgement. We acknowledge the digital technology which has made this session possible as both exploiting the resources of Indigenous people in many locations throughout the world and also exacerbating the persisting inequality because of unequal access to the internet and associated resources. Today's session is a panel discussion about unusual events in the South Bronx in New York City in the early 1970s, where a close working relationship developed between the Lincoln Collective, the Black Panther Party, and the Young Lords Party. Each of these groups had their own history and agenda, and the overlap led to some amazing results. Each panelist will speak without interruption for 9 minutes. After the fourth panelist has spoken, I will moderate the question and answer portion of the program. The chat function can be used freely during the presentations, but after the last presentation, we will use the chat function for Q&A. At that time, if you have a comment or question, please type the word stack into the chat and I will call on people in the order in which they signed up. Our first speaker is Merlin Chakwanyan. Merlin is a historian and an assistant professor of socio-medical sciences at Columbia University's Mailman School of Public Health. His book, All Health Politics is Local, Battles for Community Health in the Mid-Century United States, will be out later this year from the University of North Carolina Press.
Thank you so much, Ken, and thank you everyone for joining. It's great to be here with Cleo, Charlotte, and Ollie. And as Ken mentioned, Ken mentioned this other book I have coming out, but we're currently working on a book that includes a large section on the Lincoln Collective. So it's great to see a lot of very familiar faces here, including people that I saw a few years ago when I blitzed around the country, all the way from rural Maine to San Diego, interviewing various folks. And I hope we can all see each other again in the not too distant future. This has been a profoundly isolating and alienating year, I think, for all of us. It will, even though we're digitally congregating here and it's nice, I think nothing quite matches face-to-face contact, whether it's talking about events from the past or community organizing or whatever else. It's also an interesting dynamic here, I think, because Cleo, Charlotte, and Ollie, and many of you were direct participants in events that occurred when I was not even born yet. And yet right now, I'm actually older than almost all of the direct participants were at the time of the events. So we had this kind of collective discussion, the four of us, a few weeks ago about what might be most useful and how to present this material. And we thought it might be useful if I, in my time, set some context for some of the more firsthand analyses that my three co-panelists will subsequently give. So I have 9 minutes, and if there's one major argument or thesis or just grand point that I want to make in that 9 minutes, it's this. The Lincoln Collective and the health organizing in the South Bronx, particularly around a group you'll hear about from Cleo, the Health Revolutionary Unity Movement, it didn't come out of nowhere. It had roots, both in the zeitgeist of the 1960s and earlier waves of medical student activism. And that's what I'm going to talk to you about now. And again, it's 9 minutes, so there's a lot of compression going on here, but we can probably elaborate it a bit more in the Q&A. I also know there's a range of people on this call. So many people on this call are direct participants. And so some of this is going to be very familiar territory, like eye roll kind of stuff. But there are others here, I think, who are in their 20s and 30s and maybe even in their teens who might be less familiar with some of this stage setting. And so some of that stuff is for them as well. But I don't think you can talk about what happened in the late 1960s, in the early 1970s, without talking about what happened in the early 1960s. So that's what I want to get to now. And let me just quickly put up this PowerPoint here. This is the moment every Zoom speaker fears the most, a PowerPoint screw up, but I think it'll be okay. All right, looks like it works. And yeah, do you all see a black square, just kind of a black blank rectangle? Perfect, great. So there are three concurrent and often overlapping movements in the 1960s writ large. This is outside of medicine itself. And the first is what you might call the student movement or the New Left. So this here is a picture of an organization that both Ollie and Charlotte were in. They were very active in the Cleveland chapter of this organization. But this is actually a photo of the founding of an organization called Students for a Democratic Society. And this is the founding in Ann Arbor. And this is the major, I guess, left-wing student group in the 1960s. And the conceptual pillar of the group is something called participatory democracy. And this is a very simple notion. It's the notion that people who interact with large, often faceless, highly bureaucratic organizations that exert huge influences over their lives and their fortunes, including health institutions, that the people ought to have a say in how those institutions are run. And this animates a lot of thinking during this era, and I think you'll see that with all of us in our presentations. A second movement is, of course, civil rights. Now, this has alternately been characterized as the Black Freedom Movement, and in later phases, the Movement for National Liberation. And the main targets in the early 1960s are legislative, and they culminate in the passage of the Civil Rights Act of 1964 and the Voting Rights Act of 1965. Many civil rights organizations, particularly the Student Nonviolent Coordinating Committee, or SNCC, which you see up here, they didn't just engage in huge marches or legislative lobbying, but also direct action. That is, where you actually put your body on the line for something like a voting drive or some other kind of cause or goal. And you'll see a lot of that too, I think particularly when Cleo talks. And I should also mention that civil rights organizing wasn't entirely within organizations. So many of us are familiar with the NAACP, SNCC, CORE, etc. But a lot of agitation also took place outside of it, particularly in things like the uprisings or to some rebellions of the 1960s. And this is a picture of the one that happened in Watts in 1965. And then finally, the third movement, which I think very much affects both students and civil rights, is the one against the war in Vietnam. Now, you could certainly call it the anti-war movement, and you wouldn't be wrong to do that, but it is also a movement against militarism and imperialism and occupation by territories by major geopolitical powers. And this has the effect of radicalizing both students and anti-racist movements. So students begin to question, for example, whether universities are complicit in the sort of militarism that they are decrying. This is a photo here of what might still be the largest student protest in American history in 1968, when Columbia University's campus was occupied. And you also see around this time the birth of organizations like the Black Panther Party and the Young Lords, both of which make national liberation and anti-imperialism, both abroad and in the United States, a core part of their political program. All right, so what does this have to do with medicine? What are the implications for medical students? Well, medical students are also affected by these broader currents, and a lot of it starts at USC, University of Southern California, in the 1960s. Now, both the medical and regular campuses of USC are located just slightly north of South Central Los Angeles and the Watts neighborhood, which I mentioned. You can see on this slide here just how hyper-segregated Watts was. I think noting this spatial arrangement is actually pretty important, because the gulf between impoverished ghetto on one hand and gilded medical institution on the other I do think really generated a lot of social consciousness and emotional wake-up moment for a lot of these medical students. I mean, I can tell kind of a similar story, not just for Los Angeles, but for Cleveland, Chicago, Boston, Cincinnati, Philadelphia, San Francisco, a lot of the other cities where medical student activism really took off. There is this kind of tension, cartographic tension that you see here. Now, at USC, two students, Bill Braunston and Mick Garvey, sparked a lot of medical student organizing. They said to themselves, look, there has to be a lot more to medical school than just biomedicine, biomedical training, and they had visions of a more responsive campus and curriculum. So this brief founding credo, I think, captures a lot of that, this expanded definition of what a physician ought to be. And it's worth reading some of it aloud, so I'm gonna do that, and you can read along as well. SHO wrote, quote, "The objectives of this organization, this student health organization, are to educate its membership to the ever-expanding role of the modern physician, exerting an enlightened and dignified influence in both the medical and general communities, upholding the best and broadest interests of human life and health." And so they put this into practice. By the summer of 1965, this Southern California area SHO group launched regular year-long work, free auditory and visual screenings of children, plus dental care for the indigent. And it also initiated what would become its hallmark projects. These were called the summer health projects. So one summer health project, just to take one example, sent 13 students to work with migrant farm workers across the state. And then the actual organization itself, SHO, spreads across the country. So besides Chicago and Los Angeles, you have the Bay Area, New York City, Boston, Philadelphia, many other hotspots, Detroit, another, throughout the country. A year later, the summer health projects scale up. So in 1966, they expand further. And this article here, Margaret Sharfstein, who had come to California from New York City, where she was a medical student at Einstein, she came to work at a public hospital, and she remarked to this reporter who was kind of chronicling the SHO and these summer health projects, quote, "Nurses and social workers go into the community. Why shouldn't doctors? The patient is a whole being with a home and a social interaction all of his own. To look at the patient as a disease alone seems inconsistent to me for the healing professions." So for many of these student participants, again, this is a wake-up call that made them rethink who got shortchanged during this era where medicine's growth and prestige were at their height. So these summer health projects were very, very successful. They got a lot of money from the War on Poverty effort, but the organization itself eventually imploded. And I think there are two main reasons for that. This cover here is from the February 1968 annual meeting in Detroit. And it kind of hints at these tensions. It asks, where are you going, SHO? And what are these? So I mentioned that I think there are two tensions, two strands. And I think the first of these is over the Vietnam War. So one heated issue at this 1968 meeting was whether the organization SHO ought to take an anti-war stand, and it did not. And that frustrated many members who had begun realizing the health costs of the war. So this same booklet, for example, carried an anti-war manifesto by Paul Epstein, one of the major SHO leaders. At this SHO meeting, another student, Mike Smith, questioned whether the organization ought to accept substantial federal funding, which had been subsidizing most of its projects. The logic behind Smith's question was as follows. If the same government that funded an imperialist war machine was funding SHO programs, was the money tainted somehow? The second reason for a change in SHO's overall mood, I think, was existential. So some SHO members started to reflect and scrutinize the organization's reason for being. And so this is one testimonial that I'll read from somebody who was kind of asked to just give what she thought about participating in an SHO project. And this person writes as follows. According to the project fellows and SHO literature, the main goal was sensitization of white middle-class medical students, a perfectly rational idea from the white students' viewpoint. But from the moral point of view, this is a horrendous injustice to the community. How can SHO invade a ghetto to help, of course, with an army of white medical students and for 10 weeks perform acts of charity and fellowship, but simultaneously have the anguish of the ghetto as a secondary reason for justifying the existence of SHO? The makeup and foundation of SHO and the student health projects must be changed. So there was this concern that the projects amounted to little bit more than students parachuting in for 10 weeks, then pulling out with little long-term consequence left behind. So in my final minute, let me tie in what this all has to do with the Lincoln Collective and the Health Revolutionary Unity Movement and some of the other groups that are organizing around Lincoln. So this here is a recruitment pamphlet that was distributed to get people to become part of the Lincoln Collective. And here's where I think SHO is important. Not everyone in the Lincoln Collective, including Charlotte, I think, was in SHO. Ollie was, many others were, but many weren't. And maybe there would have still been a Lincoln Collective with SHO, but I think it wouldn't have come together so rapidly. For one, a lot of the people who were in the initial year, especially for the Lincoln Collective, were SHO members, or they had gone to SHO conferences. So the networking mattered a lot. But even more importantly, even if they had no formal contact ever with the organization, there were just a lot of ideas in circulation about the political dimensions of practicing medicine that came out of SHO, and that I think infused a lot of the activism you're going to hear about from my three co-panelists. I've always seen what happened at the Lincoln Collective as, in many ways, an attempt to improve upon the shortcomings of SHO activism and the short-term nature of some of those summer projects. And so you're going to see a lot of, I think, this SHO kind of core, these core beliefs bleed in to the Lincoln Collective, but the Lincoln Collective evolved them more. I'll end with this. This is something from the Cleveland Summer Health Project of, I think, 1968 or 1969, but I put it here because Ollie, I think, headed it, or at least he's named as the head of it when he was a student at Western Reserve. And I think it's just a very fascinating thing. So this was the application you had to fill out if you wanted to be part of the project. And, you know, there's kind of this usual stuff in the application, but then it asks, I think, some really fascinating questions that, you know, you kind of wish certain residency programs now would ask, right? They ask the students whether they think community people should advise medical personnel on budgets, on the scope and practices of the medical center, on the hiring and firing of medical personnel. So there are some real questions here that get at not just one's skill level, but one's fundamental beliefs in participatory democracy and how much it should or shouldn't involve health. So that's my stage setting. I'm really looking forward to hearing from my co-panelists. Thank you.
Thank you so much, Merlin. I must say, I also have thought about SHO as being behind, being the network that made Lincoln possible. Our next speaker is Cleo Silvers. Cleo played key roles in events that led to the 1970 People's Takeover of Lincoln Hospital. She now lives in Memphis, Tennessee, where she's active in the movement there as well. Cleo? You're muted. You need to unmute.
I just unmuted myself.
Good.
I just want to say hi to everybody. I recognize just about every name that's there, and I really appreciate seeing you guys again. And I really appreciate the work that we did together to make changes in the quality of healthcare for people in the community, both in the South Bronx and all over the country. I just want to begin by saying that I came into Lincoln Hospital as, first of all, a VISTA volunteer, a part of that same movement that brought all of us together. And after I left VISTA, somebody said to me, well, if you want to stay in the South Bronx, and there was a lot of stuff that we did in VISTA. In VISTA, we did the housing struggles, and we struggled over the quality of housing and the horrendous way in which the landlords maintained the buildings. We did code enforcement, and we started doing rent strikes. And I have to say that, and I want to give a good shout out to Afeni Shakur, the mother of Tupac Shakur, who was one of the most prolific housing organizers and one of the people that led the struggle for doing rent strikes in the South Bronx and in Harlem. And that there are still buildings in Harlem and the South Bronx that that are owned by people that live in the community, that lived in the community, and sometimes their children by now. I want to just also clear up that I came into Lincoln Hospital as a community mental health worker. So the community, I became a member immediately of the 1199 chapter, the Lincoln Hospital 1199 chapter, which was known as the Renegade chapter of 1199, because all the mental health workers there had several demands, and that there had been a takeover of the mental health center by my first 2 weeks there. And our demands were training and upgrading for the workers, an end to the use of psychotropic drugs that did nothing to really speak to the social and economic conditions that people faced, and respect and dignity toward the patients. And that was the bottom line, was that one of the major issues was respect and dignity from the doctors, the nurses, the social workers, everybody. And that patients should be receiving and should be treated with as much respect and dignity as possible. While I was a member of the 1199 chapter, the Renegade chapter, members of the leadership of that chapter were connected to the Black Panther Party. As the Black Panther, Aubrey Dawkins had a dojo, and his dojo was connected next door to the Black Panther Party office. So that's how I was introduced to the Black Panther Party. And the one thing that brought me closer to the Black Panther Party was their role in fighting for the sickle cell anemia to be recognized as a disease, and to be for there to be a research on the disease and sickle cell anemia. So, and then later on, one of the most important things I think that we need to talk about probably was the coalition and the relationship between the workers at the hospital and the Lincoln Collective. And that's how I became connected to the Lincoln Collective, because of what I recognized as a need for the workers and the community to understand medical issues and issues of healthcare delivery, and that I couldn't do that, or that we couldn't do that. It would be impossible for us to do that without having the support and the information that the doctors had. And that's how we saw it. As the doctors got the information, we need that information, but we need to be able to break it down so the people in the community can understand what we're talking about. Because it would be impossible for us to wage a struggle in the community without the people in the community supporting what we were doing and understanding what we were doing. And of course, ATRUM. And ATRUM was an organization. I'm gonna have to have my nitroglycerin. Gotta have ATRUM was the connection between Gouverneur Hospital workers and Lincoln Hospital workers, and we were brought together by the Young Lords. And I think all these organizations and our relationships are very, very important. And I do want to spend as much time as I can answering questions. I'm going to give up 2 minutes of this, and so that I can answer questions. But finally, the last thing that I think is so important is that the struggle for free, quality, preventive health care continues on today. Is that all of the work that we did and all of those years that we engaged in struggle, that this question of why in the United States of America we cannot have free quality health care and we cannot have door-to-door quality health care for people who need it has to be like the central question for healthcare delivery in this country. And I know that people get mad and I sound like a broken record, but this is what I started out believing, and I still see the necessity for it. And I believe that we can do this. I believe it's possible if the same groups of people are able to work together to struggle in this direction. So finally, I wanted to talk about doctor education, but I think that we can cover some of these questions about everyday doctor education and whether or not the new doctors have to know that when they come into a community that is disenfranchised, or they come into a community that is poor, that they have a responsibility to recognize every patient as the same as they would recognize their own mother or father. And that the quality of care that should be delivered to each individual patient in every community, including Memphis, Tennessee, should be the same as they would want for their own parent. And I don't want to forget that the Patient's Bill of Rights that we were able to pull together, bring together during that period of time still is still on the walls of every hospital room in the United States, with the exception of the hospital that I was in last. And that although it's significantly watered down, that the patients still have rights, and that we need to fight for the original Patient's Bill of Rights. So I'm giving up my time now. Thank you.
Cleo, do you want to go through those photos quickly?
Sure, please.
Let's see if we can get them up here. Cleo's photos. Everybody seeing the screen share?
Oh, okay. So that's the takeover. One of the takeovers. I think the Lincoln Hospital takeover with the Young Lords.
Let me know when you want me to go to the next slide.
Move on to the next slide. This is the next slide. This is a pretty important slide, this next one. That's me at a rally in the South Bronx around the question of, and there's some doctor in the back there. And we are talking about healthcare. And this gentleman here on the far right is Zaid Shakur, who was my Black Panther mentor, who was a very kind and brilliant member of the Black Panther Party, who really fought hard for all the issues that we fought for and helped direct us, along with some of the leadership of the Young Lords organization. Keep on, you can move on. This is a picture of what it looked like to be a part of the takeover at Lincoln Hospital, in the room where the Young Lords gathered before the takeover. Who is that? Henry Squire coming in here? I was one of the doctors from the Lincoln Collective coming in the window.
Looks like Peter Schnall.
It's Peter Schnall, that's who it is, exactly. Peter, I see you there. Coming in the window with the young lords during the takeover. The next one.
Peter thought it was an AMA convention.
And of course, this is me, the 24-hour maniac. I was a maniac at the Think Lincoln table. I know that people know the stories of how many times the security guards took us out of that emergency room, and we brought our table back, and we learned how to do triage there, and that's such an important part of it. Ending racism in medicine, healthcare is a right. Those are real important slogans. We're going to talk about that later on. You want to move on? Next. This is a couple of doctors. Who's that? Henry Kahn? No.
No, that's Fitz.
That's Fitzhugh Mullen. And I think that's it for that. I don't want to take up any more time, but if anybody has questions, I'll be happy to answer them as we move along.
Okay. Our next speaker is Charlotte Phillips. Charlotte is a primary care pediatrician. She worked at Lincoln Hospital from 1969 to 1977, during which time she was co-founder of the Lincoln Collective. She was also my clinic supervisor. She's the one who taught me pediatrics. After 14 years out of practice, she worked in the New York public hospital system in Brooklyn, New York, retiring in 2012. She's currently the chairperson of Brooklyn for Peace.
Thanks, Ken, for the introduction and also for your person's work that you have done to organize this panel and to bring it together. It's really uplifting and exciting for us to be here tonight with everybody. So I'm going to share my slides at the beginning so I can be sure I have them there. Great. So I came from Cleveland, Ohio to Lincoln Hospital in February 1969 to complete my residency in pediatrics. During both college and medical school, I had been fortunate to be active in the student civil rights movement of the 1960s, the Student Health Organization, and the movement against the Vietnam War with Students for a Democratic Society. My decision to go to medical school was based in large part on wanting to acquire a concrete and useful skill which could be used in movement building over the long run. Moving to New York, a decision based on my partner's legal case as a conscientious objector, and looking for a residency which would accept me in mid-year, I was lucky to meet Dr. Lou Fraud, chair of pediatrics at Albert Einstein College of Medicine in the Bronx, and to find an opening at Lincoln Hospital in the South Bronx. And this slide shows a typical street in the South Bronx. On the left and on the right is the front door of Lincoln Hospital. The broken windows here are emblematic of the state of disrepair of the building. There were a few air conditioners in the administrative offices, but most patient care areas had no air conditioning. And this slide shows the group of residents whom I joined. In the months of 1969, after I arrived, the Health Revolutionary Unity Movement, which Cleo has described, formed as a group of health workers opposed to the established hospital unions. Their principles, which you can see on this next slide, included community and worker control of healthcare institutions, and they were very compelling and exciting. In December 1969, HRUM joined forces with the Young Lords Party, which was organizing in East Harlem and the South Bronx, where the Black Panther Party was also active. The idea of forming a critical mass of residents who would be able to provide mutual support to each other during residency training developed during my early months at Lincoln Hospital. I met up with other pediatric residents at Jacoby Hospital in the North Bronx, who had also come out of the Student Health Organization. And together, we hatched the idea of a community pediatrics program. We hoped to counteract the alienation and loss of idealism which so often occurred for young physicians during the years in training. Our program would value and encourage social commitment, community service, and non-hierarchical relationships. And you can see our basic principles here. We would join with residents and community partners to focus on common health conditions, the diseases of oppression, rather than rare diseases. And we would address the social determinants of health before that was a popular term. Our proposal was accepted by the director of pediatrics at Lincoln, and we recruited almost 36 like-minded residents to come to Lincoln starting on July 1st, 1970. This was a small miracle when you realize that it was before the days of email, Facebook, and Twitter, and even long-distance phone calls were expensive and we rarely made them. I was the chief resident in the program. During that summer, events in the national anti-war movement, as well as in the South Bronx, swirled around us. We were inspired by the 10-point program of the Health Revolutionary Unity Movement, which you can see here. Also, the 10-point program of the Young Lords, and we can share these slides later if you'd like to keep them for reference, and the Black Panther Party. It's striking and actually almost heartbreaking that all these demands are equally relevant today. Although it wasn't easy as we grappled with the reality and difficulties of providing the best possible care to patients who came to us, we did our best. Even during the takeover and the tumultuous days when the hospital was taken over by the Young Lords on July 14th, a mere 2 weeks after our program kicked off, we tried to operationalize those demands and to put the principles into practice. We tried to respond to the patient complaints which had been collected by the community members in the Think Lincoln Committee who staffed the complaint table at the entrance to the emergency room, which Cleo has described. The programs we developed seemed revolutionary at the time, but now have become a standard of care in residency training programs. For example, a key demand was to reduce the waiting time when patients came to the clinic and to have continuity of care with a doctor whose name you would know rather than a different doctor on each visit. The idea of continuity of care in a clinic setting was virtually unheard of in 1970. The idea that every patient deserved a physician who was responsible for their care, whose name they would know, and whom they could expect to see on every visit. To enable this, we reorganized the clinic schedule to be able to give timed appointments rather than block appointments, where families might wait up to 4 hours or more before being seen. To make it a priority for whoever was assigned to the clinic to be there on time, we reorganized our work schedule on the inpatient service to provide coverage for whoever was scheduled to be in the clinic so that they actually could be there on time. As doctors, we introduced ourselves by name and addressed the parents with the appropriate last name rather than as mom or dad, which had been the commonly accepted practice. We also instituted a night float system, providing coverage for the midnight to 8 a.m. shift by a separate team and eliminating the schedule of 24 hours on call with 8 hours of work the next day, which was the general mode in most residency programs. The quality of care improved almost overnight with this change, as decisions were no longer made by overtired and sleep-deprived physicians. We incorporated patient education into the clinic visit and tried to prioritize preventive care. We developed guidelines for care for basic health conditions so that the doctors could be held accountable. We reorganized the charts into a new format, the subjective, objective, assessment, and plan, so that follow-up could be more systematic and medical errors could be minimized. We tried to break down the traditional hierarchy in staff relationships. We proposed inviting parents onto the selection committee. The collective expanded to include residents in medicine and psychiatry. When we learned that the Black Panther Party was organizing a free health clinic in the neighborhood near Lincoln Hospital, and that the Young Lords were doing outreach screening for lead poisoning and tuberculosis, we volunteered to provide clinical services to support their programs, as well as technical training for their health workers, and we built a community service rotation into our program. Our connection to the Black Panther Party led to the sequence of events culminating in the resignation of Dr. Arnold Einhorn, chair of pediatrics at Lincoln, in December 1970. He was replaced by Dr. Helen Rodriguez-Trias, a visionary leader who was able to go with the flow of our community-oriented program while shoring up our academic foundations. Helen subsequently became a national leader in the women's health and reproductive rights movements, as well as other arenas, and served a term as national president of the American Public Health Association. The New York City fiscal crisis of 1975 and the austerity regime which followed led to budget cutbacks which made the provision of care even more difficult. At the same time, the COINTELPRO program decimated the leadership of the Black Panthers and the Young Lords. I'm not sure we were aware of that at the time, but in retrospect, it seems very clear that that is what took place. They lost their focus for the free breakfast programs, health programs, and other outreach organizing in the South Bronx. And also the anti-war movement, which had brought a lot of us together, evaporated as the Vietnam War came to a close in 1975. Although the United States' imperial mission in the world did not evaporate and continues pretty much unabated until this very day. In any event, many of our initial members completed the 3-year residency program and moved away. I stayed on at Lincoln as a junior attending through January 1977 and was there for the move to the new hospital. However, after the birth of our first daughter, and without the support of the collector to enable a part-time work schedule, I left Lincoln in January 1977. And these slides show the demolition of the old Lincoln Hospital. We just happened to be driving by in time to take these photos.
Wow.
Yeah, there's this one.
Jesus.
Yeah, and this one.
Jesus. Pictures.
So to wrap up, I think it's fair to say that everybody who came through the Lincoln Collective feels that it had a significant impact on their lives and subsequent careers. Hopefully, the patients whose lives we connected with felt empowered to demand what they deserved in future encounters with the healthcare system. And the changes that we introduced to residency training as well as patient care have now been widely adopted. But there's still a very long way to go before healthcare as a human right is a reality. Thanks to everybody for being here, for caring, and for all the work you have done and continue to do toward that goal. And thanks for listening.
God, girl.
And I'll try to stop sharing if I can figure out how. Did that stop sharing?
Yes.
Yeah, okay.
Thank you, Charlotte. Our next speaker is Ali Fine. Ali is a practicing general internist and associate dean for affiliations at Cornell Medical College. One of his primary goals has been to get the Cornell medical students off the Upper East Side of Manhattan and into Brooklyn, Queens, and the South Bronx, where they can work together with a more diverse community and group of clinicians. Little wonder that today Cornell is the academic affiliate of Lincoln Hospital. Ali is also chair of the board of the New York Metro chapter of Physicians for National Health Program. Ali?
Okay, thank you, Ken, and it's really nice to see so many of you here. I'm trying to get my slide up. That thing has not occurred here. Yeah, no, you all can't see anything, right?
No.
Not my slides. All right. And I can't get to that. It was there before. I apologize. Oh, a mess has occurred.
Can anybody help you, Ollie?
I don't think so. I mean, I don't know why this isn't working. But let me just start, and you know, we don't need the slides altogether, I think. My task was to, I think, describe the origins and the development of Health PAC, the Health Policy Advisory Center. But before I dive into that description, what I'd like to do is describe the healthcare environment of the 1960s. From the patient perspective, every day, 3 million Americans actually searched for medical care, and over 70 million had no health insurance. Finding a doctor or a hospital that provided quality medical care at a reasonable price was becoming increasingly difficult. And before the passage of Medicare in 1965, hospitals were segregated. In the South, Black patients were in separate wards or not even admitted to the hospital. And in the North, Black patients were disproportionately triaged to open-bedded wards or to public hospitals. From the patient perspective, healthcare was so unjust, chaotic, and unorganized, it didn't serve patients. And from the provider's perspective, the healthcare environment of the 1960s was one in which most doctors were in private practice and billed their patients with fee-for-service. And the biggest doctor organization was the AMA, the American Medical Association. Hospitals existed in various categories: nonprofit, for-profit, public, each struggling for its own survival, and many different kinds of health insurance, for-profit and not for profit, most based in employment with variable coverage, different prior approval rules, and every insurance company having different reimbursement levels. So from the provider perspective, the healthcare system appeared again so chaotic, it was a non-system. And then in the middle of the 1960s, there was the taste of healthcare reform. Medicare and Medicaid were passed by Congress in 1965. These were limited forms of public health insurance, Medicare limited to those over 65, Medicaid limited to the poor. The AMA, as we all remember, opposed Medicare and spent $5 million lobbying against it. We were then in medical school, and there was the case of Robert Ebert. There were only 3 doctors that came out in favor of Medicare in Cleveland. One of them, was Izzy Weisberg, a pediatrician. The other was Ben Spock, who was going up on charges for, helping young people avoid the draft. And the final was this guy, Robert Ebert, the president of University Hospital. Well, just to give you a sense of the power of the AMA's County Medical Society said, don't admit any patients to University Hospital. Dr. Ebert shows that he's in favor of Medicare. We have to show him that we're not. And indeed, Bob Ebert had to step down as chair of the University Hospital. Now he landed on his feet and became dean at Harvard 2 years later. And then there were the corporate forces, the insurance companies and the employers. Interestingly, they probably favored Medicare because it took the sickest and most expensive patients off their rolls. And therefore, they wanted to see that program delivered. Liberals supported Medicare, viewed the AMA as the major obstructive force to change. They emphasized the non-system of healthcare and made their goal the building of healthcare systems. And in New York City, well, the goal of healthcare reform was to build academic health systems. So, whom should students, progressives, community activists see as advocates for change, and who were the enemies of change? HealthPAC stepped into this environment. It was founded in 1968 by Rob Burlage, who was a founding member of SDS, and he recruited many of you who are on this call, right? Maxine Kenny, Ruth Galanter, Barbara and John Ehrenreich, Howard Levy, Leslie Kagan, Susan Reverby, Rhonda and Dave Kotelchuk, Vicki Cooper, and me. HealthPAC was a new left think tank that published a monthly bulletin. We reported on the health system development, such as the creation of the Health and Hospitals Corporation, an attempt to bring corporate medicine into the public system, and the growth of academic health systems at Columbia, NYU, Einstein, and downstate. But we also focused on the importance of community worker control of healthcare institutions, inspired by the community worker movements at Lincoln and Gouverneur hospitals. And it should be said, we also published a book, The American Health Empire, Power, Profits, and Politics, published in May of 1970. So to dig deeper, what we did was we looked at the variety of academic medical centers in the city, and Columbia Presbyterian seemed to be one of the major ones. And the definition of an academic medical center was that it had to have a university, medical school. There it was the College of Physicians and Surgeons, and a major teaching hospital, Presbyterian. But we also saw that, Columbia had one whole ward floor of Bellevue Hospital in those days, had a cancer hospital right next door to it, Delafield. And when Columbia was kicked out of Bellevue in 1968-69, they established an affiliation with Harlem Hospital. And then there were two community hospitals affiliated to Columbia, St. Luke's at 114th Street and Roosevelt Hospital at 59th. So the network of the academic medical center, as we looked at it, we began to see that it functioned like a system. Each component had its function. The medical school did research and teaching. The teaching hospital provided subspecialty care. The public hospital was the dumping ground for the uninsured and the uninteresting patients. And the community hospital was a source of referrals. So HealthPAC then dug a little bit deeper, looking at the boards of these academic medical centers. And when we looked at NYU, what did we see? But Elmer Bobst, the CEO of Warner Lambert Pharmaceuticals, was on the board of trustees. Warner Lambert at that time was probably the largest pharmaceutical company in the world. And then there was J. Sinclair Armstrong, the president of Bergen Instruments, which made medical supplies, surgical instruments, things of that sort. So what we realized was that these companies, which they represented, sold their products to the academic medical centers. And we said, this looks like, a medical industrial complex. So in our book, here's a quote: "The most obvious function of the American medical system, other than patient care, is profit making. When it comes to making money, the health industry is an extraordinarily well organized and efficient machine." So in conclusion, healthcare is a system, not a non-system. The AMA is not the most powerful force sharing that system. Rather, it is academic medical centers and corporations are the powerful forces, and they will in fact impact the future. There is, as we said then, a medical industrial complex. And so what we found, again, as kind of the new left, we really could not follow those liberals who backed the passage of Medicare. We had to really look at the fact that there was a system behind these institutions. And that system functioned, from our perspective, to make profit. And the enemy of change was not so much the AMA as it would be the health empire and the corporate forces that backed it. And the agents of change would be health centers and corporations. But no, that's what the liberals thought. But HealthPAC wanted to see patients, community, and health workers really impacting. And we learned again from Lincoln and Gouverneur of the importance of that territory. But it was important to realize that in the future, we would be struggling, as we are today, with the medical industrial complex. Thank you very much. I think we should be open to questions.
So the way we're going to do this is people should stop using the chat function for their discussions, though they've been very interesting side discussions. And if you have something you want to say or a question you want to ask, put under your name, just type in the word stack, and I'll call you in the order you've been, put a note up. So while we're waiting for the first person to say something there, somebody, I think Anthony Carr asked a question about community mental health, and I would just suggest that you read Andrew Scull's book, Decarceration, because yes, community mental health was being deteriorated at this time, but it actually begun earlier and had more to do with state budgets, that state governments didn't like paying for mental hospitals, and so they promised deinstitutionalization into community mental health. That got incorporated into Great Society and then got chronically under and further underfunded until it's virtually disappeared.
You have a raised hand.
Yeah, Bill Braunston has raised his hand.
Okay, go Bill.
My beloved family, I just wanted to say that the richness of Charlotte's presentation is not invested in our struggle for single payer. Our work for single payer nationally and at the state level misses the radical, rich content of what healthcare delivery has to be. And we have to begin to open up our conversations to propose a major, major transformation of that delivery system, to build in democratic assemblies at the bottom, to massively expand the public health system, to double the workforce and change its class and racial and caste character, and to speak to eliminating all health debt, all health professional training tuition, and to set up a service corps in the country and at the state level where people are exchanging 1 year of tuition coverage for service in underserved health deserts all over the country. This is an opportunity for us to really bring our passion, our hearts, our experience over these 50 years into the single payer movement, which it is gravely missing, gravely missing. So I just wanted to throw that out there. I mean, now's the time. And God damn it, we're going to make this happen in the next decade or shorter, because, you know, history and the economy and morality is on our side. It always has been.
Ellie, is that you raising your hand? You're muted.
You're calling
Yeah,
it.
there. Looks like we got it unmuted. This is Ellie Graham from Seattle. I'm surrounded by David Springer and Chuck Cowan. And the question we had for, or probably Merlin, but maybe other people, was whether there have been other similar movements to the Lincoln Collective, particularly that influence postgraduate medical training in other places around the country.
Sorry, I was trying to unmute myself. So some in the side chat, the women's health movement has broadly speaking has been brought up. I would name that as one, although there's always a tension there, and that I think is less present with something like Lincoln Collective in how much one wants to actually work with the formal medical system versus reject it. It's not a dichotomy, of course, but it's a spectrum. But I would put that there. And then also, if we want to continue the genealogy of SHO, AMSA, the American Medical Student Association. So I talk to AMSA graduates, or sorry, AMSA members now and then, and I tell them that unfortunately their group, despite the great work that they may be doing now, actually has some rather unsavory origins. And so the unsavory origins are that in the 1950s, the AMA basically red-baited an organization called the Association of Interns and Medical Students out of existence through a series of McCarthyite attacks in the Journal of the American Medical Association. And then they started this kind of puppet organization called Student American Medical Association. And then in the 1960s, in response to SHO, some of the more moderate medical students who thought SHO was a little too radical for them, took over Student American Medical Association and, you know, made it a more legitimate organization. And they eventually did a name change to AMSA. And I will say that some of the SHO principles I do think live on in certain AMSA chapters. They've been very active recently on undocumented, the healthcare access for undocumented people in the United States, in the movement for Black Lives, in just curricular reform issues, reforming competencies and so forth. So I put that as another possibility too. And then I think third, if you just scour any medical campus, you'll see that every medical school, including a very parochial one like the one that I'm associated with, they all at least have to genuflect that they care about the community somehow. And often this is in the form of some kind of charity care or outreach program. And, it's often very tokenistic, but at other institutions, it's a little bit more sustained and meaningful. And so I would say that is also a response to some of the activism that we've heard about today, either a direct response, sometimes more often an indirect response. I'm sure if we canvass this virtual room, many of us could list other initiatives like that.
The next person on stack is Bob Lederer.
Good evening. This is a fantastic discussion. I want to thank all the panelists for teaching us a lot about that period of time and all of your great achievements. I have a particular question for Cleo. Good to see you, Cleo. You were very involved in another form of medical activism at Lincoln, which is really, really important, but not discussed enough. And that's the storming of the hospital in November of 1970 that led to the creation of the Lincoln Detox program for the People's Program for detoxification from initially from heroin addiction, but it broadly expand over the next several years for all forms of drug use and alcohol use, cigarettes, and a lot more. And within 2 years brought in the revolutionary methodology of acupuncture and found fantastic results in detoxing using that. So you were a key player in that, along with, of course, the Young Lords and H. Rum, and later some Black Panthers and other Black activists. Can you talk about some of what you went through, and also what the lessons are? That was shut down by Mayor Koch in 77 with 78 with the direct involvement and complicity of Chuck Schumer, then climbing ambitious assembly person who demonized Lincoln Detox, accused them of terrorism, and helped set the stage for the armed raid by the police that shut down Lincoln Detox.
Thank you, Bob. That's an excellent question. Hi, Ellie. I just want to say that I started out by talking about Lincoln mental health services, community mental health services, and that's where the concept and the idea came in, because many of the 1 in 4 members of the South Bronx community that were addicted to heroin came before Lincoln Detox. So it was the community mental health workers that really came up with the idea and the thought that what was necessary beyond a methadone maintenance clinic, which was the only thing that was available at that time, was the need for a clinic that, for drug rehabilitation that did not include another drug. So the concept, we began to talk about that back then. It was the Black Panther Party and the pamphlet, Capitalism Plus Dope Equals Genocide, that was the basis for our discussion with the mental health workers' discussion with the Black Panther Party to begin to talk about the need for that drug detoxification program. And Lincoln Detox kind of started with 2 drug addicts that I met on the street while I was selling the Black Panther newspaper, that's Panama Alba, and a brother named Butch. And we connected with members of the Lincoln Collective, the Black Panther Party Young Lords, and the actual drug addicts. And yes, we did go in and take over the nurses' residence of the mental health services and demand a drug detoxification program. Dr. Mutulu Shakur, I hired him as the executive director, and he, along with Panama and some of the other comrades, began to think about other ways of detoxing people who were addicted to heroin. And they began to, of course, because they were reading the Red Book and reading about the barefoot doctors in China, they connected with those ideas and decided to use acupuncture as a methodology. And it was those people, those activists, those people in the community who came up with the 5-point protocol for acupuncture to detox people from the use of drug addiction. It was not Dr. Mike Smith who came in and said, and built this organization called NADA based on what he said he did, but he did not. It was Mutulu in Panama. And thank you, Naomi. You recognize that this is a real history it did not have to do. And although NADA is like a huge international organization today, our comrades should receive the recognition for all that they did to change the methodology and the way in which drugs are detoxed, people are detoxed from the use of heroin. So thank you, Bob.
Thank you, Cleo. The next person on stack is Anand Bhatt, but get back to your chair.
Yes. I didn't want to eat while asking the question. So yeah, wow, it's like this huge like encyclopedia of like medical history knowledge I didn't know about, and I was in AMSA for many years, and I heard some of these stories, but I didn't know all of the stories. So I'd heard about these projects, but you know, that's like 10 years ago now. But I wanted, I guess I have two questions based on all of this. I went to graduate school between my third and fourth year of medical school, which when it got hit by a hurricane in Texas. And I saw some straight up disaster capitalism with austerity being, we didn't have the words for it back then in 2008, or at least I didn't, austerity politics, and they cut care and everything. But I got a master's in health policy, and I remember coming across this MedPAC book, Healthcare Empires, in the London School of Economics library. And I just thought it was the most crazy, insane, foresightful book that was like speaking from the past to me like 30, 40 years later. And I thought, like, what happened to this organization? Why don't we have anything with like a left perspective actively doing research? Because of everything I was trying to write, and I lacked the language for it. I wanted to have an analysis of neoliberalism in healthcare. And in 2010, when I was 2009, 2010, I lacked the language for it. And this MedPAC book of Healthcare Empires helped me kind of see the patient referral industrial complex. And it was absolutely brilliant. I just can't believe I'm running into y'all who wrote that. So I was sort of so right now, Ken knows me through the Democratic Socialists of America Health Workers Collective. We've kicked around the idea of some sort of research and political education group. How can we restart something like that now? Because I'm seeing crazy stuff in the hospitals these days that you couldn't even imagine of. I just found out that the RNs in my hospital are being outsourced to Jamaican nurses and African nurses for $10 an hour, who probably aren't even qualified. And it's like all sorts of stuff that's happening, like McDonald'sization of medicine, and we lack a language to do this. And I think we need some way to describe these issues. The second one I had was, I think Cleo Silvers mentioned the rebellion in the union to do what she was doing. And I wanted to know more about that, because what I've seen, I'm not from a union state. I live in Louisiana and grew up in Texas. I haven't seen a lot of unions, but I hear a lot of people complaining about the conservatism of unions. And why aren't they there? Why aren't they helping us with healthcare? Because I haven't seen anyone besides the nurses union fighting for healthcare from what I've seen. And that was only in Ohio that I saw that. So what did you mean, and why did you guys have to rebel?
Leo, you want to start?
Sure. Thank you. That's another excellent question. I want to say that 1199, which is the hospital workers, is the very largest hospital workers union in the United States, was where we began. We became a member of the of 1199 in 1968, and at that time it was the war, the Vietnamese War, and several other things going on. Simultaneously, the students had taken over Columbia University. And one of the things that was clear was that the union was not taking a strong enough stand. It was not taking what we considered to be a union stand in its demand for the things that the workers needed, just decent respect as a worker, a decent salary, the respect as the work that the community mental health workers did brought the professionals closer to the community, because we were from the community. That was not recognized by 1199, it was not recognized by the union. But historically, that I've also been involved with the UAW, because I left Lincoln, sadly, to go work at for the League of Revolutionary Black Workers in Detroit. And I worked in an auto plant for 5 years. And that was the struggle inside there, that Black workers and workers of color were being discriminated against inside of the organization, which was why there was a need for a League of Revolutionary Black Workers. So the struggle to bring the unions to the position of its progressive, the progressive role of the working class and to represent the working class properly. It's like been a key struggle historically, and we're still in the middle of that struggle. The labor movement has to stand up for the working class, or else, and that the working class has to be respected in terms of its in terms of delivery of quality healthcare to us. And if somebody asked me just what would be my my favorite and most important job in life, and that my most important job in life, if fourth graders ask me this, is to be the director of how to allow and how to encourage doctors to respect patients and to give the quality of healthcare that's necessary, and to do it free in this country. So
Anand asked another question, which essentially is, what would it take to rebuild the research capacity of HealthPAC and to rebuild that institutionally? And I don't know, I guess Merlin or Ali might address it, or if somebody else wants to.
I have some thoughts on that, but Ali, I think as somebody.
You go ahead, Merlin.
I mean, I think the interest, I occasionally, so Ali and I were involved in a project a few years ago, along with Fagel Jacobs, who I think is on this call, and Susan Reverby, to digitize the entire run of health packs. And so I hope our labor was not wasted. So go to www.healthpackbulletin.org and you can see them all. But occasionally I'll run into somebody, usually it's a young physician or a medical student, who will see them and be wowed by the fact that it managed to intertwine activism and research, and they will say, why don't we rebuild something like this? And my instinctive reaction is usually, yeah, that would be awesome. But then, my second reaction is, I actually think HealthPAC changed a lot of the medical opinion publishing landscape in ways that might not be immediately apparent, but that are when you think more closely about it. For one, a lot of people in HealthPAC went on to policy roles or other roles in the healthcare sector and brought those ideas to them, or a lot of people read HealthPAC and then moved into, say, a foundation and kind of imparted those values onto that foundation. I'll give you one example. Alonzo Plow, who is I think the head of research at RWJ, the Robert Wood Johnson Foundation, by no means a radical foundation, but he's like, number 3 or 4 on the food chain there, was an ardent reader of HealthPAC and occasionally came to reading groups and talks about how important that analysis was in shaping him. And I do think, even if you look at something like God forbid, JAMA or NEJM, if you read between the lines, you will not see the words American Medical Empire, Medical Industrial Complex in their analyses. But I do think a lot of the critique of the irrationalities of the system and medical waste and people who exploit that are in there, if you look carefully enough, in ways that they weren't pre-HealthPAC. So in some ways, HealthPAC may not need to exist because it kind of exists subtly in this form. But whether or not it's a good idea to revive something like that, I think, is an open question. And I'd be curious to know what you think, Ali, as somebody who had a big hand in creating this amazing thing and was very much influenced by this. And, you certainly see the landscape in different ways than I do.
I would just say, you know, one of the really impressive things now around the Black Lives Matter territory, frankly, is the student movement that has come up within, for instance, PNHP, the SNAP group, the Students for a National Health Program, here in New York, has begun to be one of the major forces pointing out, you know, that the attempt of the governor to close hospitals in Brooklyn and in Mount Vernon and so on, in spite of the need for hospital beds because of the pandemic, there is, you know, I think among young people now, a building of a movement to do more of the research and activism that was characterized by the 1960s.
Great, thank you. Next person on stack is Musab Khan.
Hi, thank you. Thanks for this talk. I'm a resident in New York, so I'm kind of in the midst of a lot of what has, I guess, been organized in the past at Lincoln Hospital. My specific question, I think, is for Merlin. And I think, Merlin, you might have spoken to my residency program last year, if I'm remembering correctly, at Montefiore, but I might be misremembering. But my question is, where can I learn more specifically about the details of how the folks in Lincoln Hospital structure their residency programs, and whether or not that's covered in the books like White Coat's Clenched Fist or the other book mentioned? And if not, where can I just learn more? Because I think one of my goals is to try to hopefully get residents to organize around very tangible things that then we can bring to our residency program from the lessons learned at Lincoln.
Cleo has several firsthand essays that are just kind of around and I think easily accessible if you just type her name in Google. And so I think that is a huge resource for learning about some of the events that she talked about, and she may have others that she has in mind too that she might want to share. Another is something that I saw come up with in the chat, and it's Fitzhugh Mullen's memoir, White Coat, Clenched Fist. I think one thing to remember, and I think Fitz would agree with this, Fitz was also, alongside his many roles, a historian himself. He wrote a book on the United States Public Health Service and, miscellaneous articles on historical aspects of the public health system and so forth. So he would be the first to tell you that the memoir itself is his rendition of the Lincoln Collective events. One of the things that's been fun for me while researching the Lincoln Collective is to figure out how to write it in a way that isn't simply replicating Fitz's recollection of it. And so that difference between a memoir and kind of more critically distant history has become even more apparent to me. So I think as long as you know that's what you're getting when you read a memoir, that's the kind of rule with any memoir, I think. That is another fantastic resource. And then Susan Reverby, who I noticed is in the chat as well, has a biography of a figure who I think was, I guess, orthogonal or tangential, I don't know what the right adjective was, but about a very important figure, Alan Berkman, who was also a revolutionary physician in some of these orbits, and Lincoln is touched on in that book as well. And I'm happy to send you some stuff too if you just email me. And I do believe I did speak to your residency program.
I just wanted to say that we probably should not forget Harold Osborne. Also, Ozzy, I don't know if he wrote very much about his involvement in the organization beyond the struggle, but I know that he particularly was involved in, along with Charlotte, in the development at of the new Lincoln Hospital and the protocols there at the new Lincoln Hospital. So
Allison Goldstein has a question in chat. when she asks, can you please tell us what you think, this is a general question to the panelists, what you think about the state of health justice in the US today, and I think particularly appropriate today, what lessons can we draw from your experience for the present and the future? Henry, you're smiling. You want to say something? No.
Well, I think it's clear that many of the reforms that went on in the collective and, you know, the attempt to include community in a much major way, we haven't moved that much with respect to that input into the healthcare system, so that there is really a lot of potential there. And then it seems to me, I mean, although Bill Braunston seemed to downplay, it seems to me, the need to have universal coverage, you know, publicly funded, single payer, national health insurance. That is, it seems to me, crucially, you know, is really very important as a step that would allow us to begin to also address some of these other problems with the delivery system that are, yes, major problems as well.
So I just want to interject a piece of an answer to that question, which is I work, and several of the people on the call work in DSA, which is in effect the continuation through several generations of SDS. And we have a very familiar problem that we are basically white, upper middle class people who are trying to organize and move the United States to the left. And we've had an enormous difficulty in even thinking about how to make our movement multicultural and multi-ethnic. And it seems to me that the Lincoln experience was, if not unique, one of the few times when the New Left has worked with non-white forces to create real benefit. And if people want to comment or discuss that or just think about it, that would be fine with me. The next person on stack is Jeffrey Gordon.
Gordy. Yeah. Gordy.
No, Jeffrey Gordon.
Oh, Jeffrey.
Well, if Jeffrey's not available, we'll come back to him. Gordy, you have a question though. Gordy, you had your hand up, or was it Marge?
Right, yeah, I don't know what stack is actually, so sorry, chat, but so I have two questions.
Speak into your microphone.
Talk louder, just
All
talk louder.
Two questions I'd like to raise, or issues I'd like to raise. Can you hear me okay, Ali, everybody?
Yes, a little bit better.
One is sort of things external to the collective, and one is more internal. One thing that wasn't mentioned, but I think is really important, I don't think I'm just being self-serving here, is the influence of the Lincoln Collective on similar collectives in other cities, or similar critical mass of people coming to, for example, Detroit, the Norman Bethune Collective, Cook County Hospital, people coming together there, probably a couple of other cities. The Lincoln Collective was enormously influential, and in some ways it lived on longer in some of those other initiatives, which is the second question I wanted to raise is a little bit more about the internal dynamics and what was happening within the collective, especially, you know, given we heard at the beginning, the idea was not to just have a flash in the pan, an SHO summer that lasted 10 weeks, but really in the scheme of things, the Lincoln Collective was lived. And what were the, I mean, obviously there were external forces with repression and, you know, probably peace. We now know with lots of movements, but what were some of the internal dynamics and even things that you would say the Lincoln Collective mistakes or self-criticism that would be lessons of things that were learned in different directions it could have gone?
I just want to say something about the need for community control of healthcare and the importance of patient worker control, or patient worker leadership in relationship to those workers, doctors, quote unquote, workers who are delivering the healthcare to the community. I think this is a really important issue. I know we're not going to be able to discuss that tonight, but it has to be raised. It has to be brought to the forefront, because doctors cannot control, as I've been saying this for years, cannot control the delivery of healthcare in our society. If they do, it's going to continue on like it is now. So that's my answer.
I feel like there are a lot of people here on the call who were active in the Lincoln Collective, and the question you raise is one that really, should be another gathering. I think it was proposed, and maybe that could happen either virtually or in person, but I think to really talk about what were the lessons learned and what were the internal dynamics and so forth. So I'm not sure there's a brief answer to that question at all. I think what did ground us, though, was that we were actually trying to deliver care under very different and tumultuous circumstances. And we did, I think, as I said before, really do our best to try. And, and I do hope that had some impact on the patients that we actually encountered. So, but I think what grounded us was that we were actually trying to deliver care in the best way that we were able to, but at the same time, trying to live up to what Cleo has described as working with community members and other kinds of health workers in terms of trying to devise what the program should be and how we should go about it and so forth.
That actually is quite responsive, Charlotte, in the sense that one of the daily tensions was to what extent we were defending the public hospital, like in Chicago or Lincoln, against the tax, saying the hospital should be closed. That we were hearing that all the time, versus being outspoken and critical of the hospital and exposing the real, horrible conditions there that would give fuel for those who wanted to close the public hospital to privatize. So that was a very omnipresent tension, which I think needs to be brought forward and continue to be thought about.
So I see that Matt Anderson is on the call, and I wonder, Matt, if you want to say anything about how the social medicine program at Montefiore was different from Lincoln. It strikes me that social medicine was never quite as radical as Lincoln, but was institutionally sustainable. And they kind of complemented each other, but there are times when I felt like, why couldn't we have done that? That I think probably go beyond just having some money behind you. Any thoughts?
But Matt's in trouble, right?
Let me unmute myself there. I'm not really sure I have a good answer to your question. There were a lot of people at Montefiore that were unhappy with what happened. I mean, there was a whole saga when the hospital was taken over. But I was also interested to find out, when I was looking into some of the civil rights movements, that the head of surgery at Einstein went down with the freedom rides. So there was I'd say a strong culture that already existed at Montefiore for a much longer period of time.
Plus you had Vic.
Yes.
That helped.
Yes. What a loss.
There's nothing else in stack. Anybody else have comments or questions?
Does Ellie have her hand up?
No, that's from before. She never figured out how to get it off.
Okay, because Ellie actually worked with residents as well, and I was curious with your program out in the public hospital in Seattle. Any comments about what happened in that context?
Well, I think that it certainly is true that many of the residents who particularly chose to do their continuity clinics at Harborview Medical Center, where I worked, went on to become leaders in many of the community health clinics around the region, and actually also some of them have had, I think, really important roles in terms of global health. But you know, I think with what we had at Lincoln, in a lot of ways, of course, we were tasked with having to approach the whole healthcare system, everything from, you know, being out in the community, being in the emergency room, having continuity clinics, taking care of people in the hospital, and we had to think about that because we had very few in the way of faculty or people other than us to share those ideas with, and of course, you know, what community members and hospital workers work with us. And I don't think we have any similar experiences, really, that I can think of, at least that I know of, in residency training and postgraduate training.
The question I had is, when we look for community input, who do we recognize in the community to give this input? There aren't HRUMs in Seattle, Detroit, San Diego, Chicago, New York. Where are those HRUMs? And, you know, if we get community input, how do we identify who's giving, you know, where it is?
It's more than just having patient representatives on an advisory board.
Yeah. I just want to answer that by saying the people that are not taking money from the system and that really care about the healthcare, about the delivery of healthcare. And I think that's pretty easy to find those people, because it's not the Raymond Velez's. It's not the, you understand where I'm coming from here? It's not the people who are taking money from the system, but the people who show and display their interest and concern about the quality of healthcare. Locally organized people. Go ahead, Bill.
And there are some examples in Seattle of some of the ethnic communities that have really organized. The Somali community, for instance, is very organized and very community driven. And there are elements of that within the Latinx communities as well. And the urban Indian community is another example of sort of isolated groups that are really trying to influence the healthcare system. And I guess I just want to add one other thing about the other people that have mentioned about the next generation. It seems like, at least what we're seeing at the Children's Hospital in Seattle, with the current group of residents and fellows, is a huge amount of interest in issues of equity and issues of diversity, racism, community involvement. So it feels like it's the 60s all over again with at least this younger population. And I'm hoping that that's really, really true.
I would like what Cleo just said, though, I would like to make a call out to Eula Hall, who really, Eula just died maybe a month ago. And many of you probably read her obituaries, but she was a phenomenal community organizer in Floyd County, Kentucky, that Jim Squire and I worked with to set up the Mud Creek Health Project. And Eula consistently worked over the years, kept the community voice going, kept the clinic going, eventually became a community, federally funded community health center. But she was phenomenal, and she always took up other issues. The issues of the substance abuse in East Kentucky, the issues of the strip mining and the impact on the environment, and women's issues. She was phenomenal for doing that. And so one of, I think, our roles as healthcare professionals is to really identify those people who are community voices and strengthen them and amplify them.
So we have two people on staff, Dennis and Bill Braunston.
I'll keep this brief. Well, my name is Dennis. I'm a nurse in Chicago, and I joined this coalition called the Chicago Health Equity Coalition, and it's made up of community members, of trade unions, of medical students, of residents, attendings, fighting around to keep healthcare open on the south side of Chicago. And it's been effective in the sense that we've drawn a lot of attention to the issue of health in the south side, particularly during a pandemic. Cutting healthcare in a Black neighborhood is just an outrage. So it's been successful, but I think it would be great for us to maybe connect with some of the people who've done this kind of work beforehand. So I really will definitely try and reach out to people to collaborate and work towards this, because that's something that we are demanding at this point with the new buyer of Mercy, is to have a community representative on them on their board. But that's it's an ongoing struggle. I'd love to learn from others who've come before us.
Thank you, Dennis. Bill?
Really, this is a moment of profound systemic change, and I think that we can step back and not necessarily cherry pick, but say that if we can build neighborhood assembly into some kind of evaluation, ongoing assessment, and reporting. Oh shit! Just a minute. I'll call you back. Because I really, there are organized neighborhoods all over the United States. They're real. I mean, every little community has a real neighborhood that is almost a quasi-legal apparatus. And by opening up our doors and trusting that if you bring the masses of people together that are already organized around self-interest in their own communities, that there could be an enormous outpouring of tremendous energy. Of course, that's in the context of the radical, almost reparations quality significance of our single-payer models, you know, that essentially are going to transform the culture, transform the economy, transform the psychology of everyday life. I'd like to say one minor thing also in terms of self-promotion. I've been working on a book for 50 years. I was at Willowbrook at the time that the stuff was going on in the Bronx. And the book that I've written is called Public Hostage, Public Ransom, Ending Institutional America. And it essentially is an arrow at Medicaid. Medicaid is one of the cruelest and most evil systems in the country. It forces people into poverty. It's an anti-family piece of legislation. It creates a domestic refugee institutionalized community, and we've got to kill it. And so the question of not bringing long-term care into our single-payer models ever, what we need to do is to frame lifetime care rather than long-term care, and look at that as individualized planning, individualized resolution, and individualized environmental supports based on community input. It's a matter of imagination and audacity in terms of how we transform the community to deal with our most dependent members who are congregated, segregated, and exterminated in a very systematic way for money as commodities in our system. So the book will be out sometime in August on a self-published basis, and it'll go to Barnes and Noble and Amazon and so on and so forth. 380 pages, 82 photographs. It's a killer. I promise you it's a killer. And it's aimed directly at single payer as the solution to ending institutions in America as our trillion-dollar culture. I love seeing you all. I can't begin to tell you. I mean, this family is just absolutely so inspiring. I love you. I love you all.
Peter Schnall, you want to say anything about your chat comment? You're on mute.
I need to unmute. I am very happy to see so many of you, and begrudge, and I'm sorry about the fact that it's so long to have a chance to talk with you. You know, I left the Lincoln Collective pretty much dismayed and burnt out by the experience. And it took me many years to recover from it. I had an insight from Lincoln and from my work at the Martin Luther King Health Center, which I believe is critical to our discussion about the future of healthcare in the United States. I came to realize through my own studies and research around the etiology and development of hypertension in our country, that most of the chronic illnesses are diseases of modern society, and that we are socially producing mental illness, physical illness, hypertension, cardiovascular disease, and that to change medicine, we need to change the ideological model of the current medical system. And if we don't change the ideological model, which dominates our discussions about healthcare, we're not going to ever provide people with a comprehensive healthcare system which keeps people well instead of treating them when they're sick. This is why, I'm sorry, Bill Braunston, I'm absolutely opposed to the National Healthcare Program as it's currently promoted, which is that everybody should get comprehensive healthcare. I don't see how we can provide 330 million people with healthcare which is designed to treat people for their medical illnesses, which our society is producing every day by the tens of millions of people. We need a program that prevents people from getting sick. And that means social change, providing people with enough, jobs and healthy workplaces and decent society. It's a national effort. And I don't think individualized programs that encourage more people to get treated instead of encouraging more people to stay well is going to do it. So,
Peter, I absolutely agree with you, honey. I absolutely agree with you. There's
all right, good. I thought, Bill, I was going to antagonize you for sure.
I need to see you the bill that we've been working on for the last 7 months with 40 people, to show you what a really radical public health grounded single payer system ought to be, which is exactly what you're saying. How can you imagine that I wouldn't understand that after 50 years together?
Thank you, Bill. I have two more comments then, okay? Number one, when I decided that this was not possible working at Lincoln or Martin Luther King Health Center, I went back, I got trained as an epidemiologist. Some of you know this. I have spent 40 years researching hypertension and obesity as social conditions of our society. We have created a healthy work campaign at healthywork.org, where we've developed thousands of pages of information about how to promote healthy work in our society, okay? I basically gave up on the kind of political activism that we did in the 1970s because I realized it was premature. It was a wonderful idea, and I love all the people who tried to do it, and I admire them, and I believe, in retrospect, we need a different structure for how we're going to move forward in the future. So, I hope that there are many of you who want to continue to work on this. One of the things I would love to see happen is a really good critique of what was premature about Lincoln Hospital. What do we need today to conceptualize differently about how to change healthcare? Okay, that's one of the things I would love to work on with people and discuss with folks. And I hope I'm not sounding too negative about what I thought was an incredible experience at Lincoln Hospital.
Can I answer one? Can I say one thing?
Sure.
I want to say one important thing that I think is important is that as long as we have situations where we're having this huge important meeting and discussion about the quality of healthcare in the United States, and we only have 3 African Americans and a few other people of color, 4 African Americans, and a few other people of color, that is the core of what the issue is, the core of the problem. We don't have enough doctors of color involved in this, and we don't have enough patients of color involved in the discussion around how to change the quality of healthcare. And the other thing is that, again, I raise that if you are a doctor and you are a white person, that you do have a responsibility to treat the patients that you serve, or the patients that you're delivering care to, as if you were treating your own mother or father, or your own son or daughter, for that matter. But that we have to see each other as equals. And until we see each other as equals and we treat each other as equals, I don't think we're going to be able to solve the question of quality health care in this country.
There are a lot of problems.
To say the least.
Any last comments? We're pushing up against 2 hours. This has been quite lively. I'm so delighted everybody could come.
We can fix this together, God damn it. We can fix it. I mean, there's no argument here around this table. There's nobody that's saying something's wrong. We know what needs to be done right. That'll make the difference. We can do it. Now's the time. We can do it.
With that, I want to thank our panelists and thank our guests.